present some of our new data where we show that inhibition of RANK ligand interactions with the compound OPGFC inhibits ovariectomy-induced growth of disseminated breast cancer cells. But first of all, some background. So we know that about 70% of patients with late-stage breast cancer will go on to develop bone metastases, and this condition is currently considered incurable. So patients with this condition are commonly treated with a chemotherapeutic agent to control their tumour growth, as well as an anti-resorptive agent to prevent their tumour-induced bone destruction. So recent evidence from our laboratory, as well as others, has shown that if you give anti-resorptive agents in the right manner, that these can also have anti-tumour properties. So we focused our work on optimizing the use of anti-resorptive agents such as zoledronic acid or OPGFC to increase their anti-tumour properties. So what happens in breast cancer bone metastases? Well, evidence from post-mortem studies have shown that the majority of patients who have ever had breast cancer have disseminated tumour cells in their bone environment. And for the majority of these patients, these tumour cells are never woken up, so they remain dormant indefinitely. However, for those who go on to develop overt metastases, these tumour cells are awoken by factors of yet undetermined origin. But when they're awoken, the tumour grows rapidly in the bone environment. And when the tumour grows in this environment, it produces factors that cause an increase in osteoblastic cells. So it causes an increase in these osteoblastic cells, which cause laydown of new bone, as well as increasing activities of these osteoclastic cells, which eat away at the bone surface, causing lytic lesions. When lytic lesions are formed, this causes a release of growth factors from the bone, which then feed back onto the tumour cells, causing the tumours to grow even more rapidly. And this is known as a vicious cycle of breast cancer growth in bone, where the tumour cell feeds the bone and the bone cell feeds the tumour. So what we're looking at is how we can use chemotherapeutic agents to control this tumour growth and anti-resorptive agents to control these osteolytic lesions so that we can break this vicious cycle. So when we first started these studies, the only anti-resorptive agent that was licensed to treat breast cancer-induced bone disease in the UK was zoledronic acid. So we had a look to see whether we could increase the potency of the therapeutic agent doxorubicin by giving zoledronic acid as well. And we modelled this in nude mice. So we used 6-week-old biopsy nude mice. So we use them at 6 weeks old because they have high bone turnover, which means that they have high tumour take in the bone. And we injected these with a bone-seeking line of MDA and B231 cells. We put the cells into the mice, and then we left them for 7 days for the tumours to develop in the bone before giving doxorubicin alone, zoledronic acid alone, or the two compounds together. And these were then treated weekly with these compounds. And we used a second treatment method where we gave the doxorubicin on day 7, and then we waited 24 hours for the doxorubicin to have its anti-tumour effects before giving the zoledronic acid. It must be noted that when we did these studies, we deliberately chose a suboptimal dose of doxorubicin so that we could see any additional effects of the zoledronic acid, and we gave a clinically relevant dose of zoledronic acid. So using these two compounds, we could see that when we gave the zoledronic acid, we caused almost a complete reduction in these osteolytic lesions that we see with the control animals here in the bone. When we graph this up, we can see that if we give doxorubicin at the same time as the zoledronic acid, this also reduces lesion formation. And if we give the doxorubicin 24 hours before the zoledronic acid, this further reduces lesion formation. But when we looked at tumour growth in the bone, we could see that the zoledronic acid alone wasn't sufficient to reduce the tumour growth. And if we gave doxorubicin and zoledronic acid at the same time, although this reduced tumour growth, it wasn't very much. But if we gave doxorubicin 24 hours before the zoledronic acid, there was a significant reduction in tumour growth in bone. So we were really excited by this data. So we handed this over to the clinical side of our team. And Professor Coleman, who's based at the University of Sheffield, designed this study known as the Azure study, where he recruited over 3,000 breast cancer patients who had either stage 2 or 3 breast cancer. And at time of diagnosis, they had no evidence of bone involvement. So these patients were randomized into two different groups, those that received standard therapy and those that received standard therapy plus 4 milligrams of zoledronic acid. And these patients were treated using the following regime at the bottom here, but they were treated for the whole 5-year duration of the trial. And then we followed these patients up to see which patients went on to develop bone metastases. And when we looked at bone metastases as first recurrence, we could see that adding zoledronic acid, so you look at the blue line here, adding zoledronic acid to standard of care caused a significant reduction in the development of bone metastases of first recurrence. And it also caused a significant reduction of bone metastases at any time. So we could say that adding zoledronic acid to standard of care delayed bone metastases in these patients, but did it have any effect on their overall survival? So this was the analysis that we did for the whole of the, for everybody that was enrolled in the study. We could see that adding zoledronic acid to standard of care had no effect on overall survival. However, we know that hormones in the bone environment have not only effects on the tumour growth itself, but they also have huge effects on bone turnover. So we did some meta-analysis where we divided the patient population up into those that were pre-menopausal when they were enrolled into the study, and those that were 5 years or more post-menopausal, so they had established menopause, to see what the effects the hormones had on zoledronic acid in the bone. We could see that in patients who were 5 years or more postmenopausal when they enrolled into the study, adding zoledronic acid to standard of care has a significant effect on survival. So these patients lived for longer. So this led to the emerging hypothesis that bisphosphonates do reduce distant metastases. However, they only improve disease outcome in women who have low levels of reproductive hormones, so those with established menopause. So we asked ourselves, why do the bisphosphonates specifically benefit patients with established menopause? So we then went back into the laboratory to model this. So this time we used 12-week-old female biopsy mice. These are adult animals, and they have low bone turnover, so normally if you put tumour cells into these, they don't grow very well in the bone environment. And then we mimicked the menopause by overectomizing them, or we mimicked premenopause by sham overectomizing the animals. And then we looked at the bone microenvironment weekly for up to day 35, and then again on day 57. And we looked at bone volume, osteoclast activity, and osteoblast activity. So the osteoclasts are the cells that eat away at the bone, and the osteoblasts are the cells that lay down new bone. And we could see that in overectomized animals, we had significant loss of bone. So this is overectomy, and this is the sham. There's significant loss of bone by 2 weeks, and this continued throughout the whole of the treatment regime. And this decrease in bone was due to an increase in osteoclast activity, as shown by TRAP ELISA here, and a decrease in osteoblast activity. And this is exactly what you see in postmenopausal women. So we could say that our mouse model did model postmenopausal and premenopausal bone environments. So what were the effects of these different environments on the proliferation of tumour cells when they were in the bone? So for this experiment, we used 12-week-old female biopsy mice, and we injected them with the bone-seeking MDA231 cells on day 0. And then we overectomized or sham overectomized them on day 7 to mimic the pre- or postmenopausal bone environment. And in this experiment, we found that following overectomy, there was a significant increase in the number of tumours that were established in the bones of these animals compared with the sham overectomized animals. And this was specific to bone, so when we looked at tumour growth in other sites, this was no difference between the sham or the overectomy. So we could say that overectomy stimulated proliferation of MDA231 cells disseminated in bone. So we know that our model mimics the menopause with overectomy altering bone turnover, and that overectomy stimulates proliferation of dormant tumour cells in the bone. So can anti-resorptive agents prevent this overectomy-induced proliferation of breast cancer cells in bone? And do anti-resorptive agents have different anti-tumour effects in the pre- and post-menopausal bone environment? So the first thing we looked at before we looked at the FCOPG was zoledronic acid, because this is what we've modelled everything on to start with. So in normal bone, zoledronic acid causes a significant increase in bone volume, and this is due to decrease in osteoclastic bone resorption. It doesn't affect the bone formation. So to model this, we again used 12-week-old BALB/c mice, and we injected them with bone-seeking MDA231 cells. We were then treated with zoledronic acid or saline control on day 4, and we overectomized or sham overectomized on day 7. And for this experiment, we could see as our control, if we overectomized the animals, we saw the increase in tumour growth in bone that we expected. But if we gave zoledronic acid, the tumour growth in bone was significantly reduced. In fact, in this experiment, it was below the levels that we found in the sham-operated. However, if we gave zoledronic acid to the sham-operated animals, so the premenopausal bone environment, then we didn't see any alteration in the tumour growth in bone. Looking at the bone environment, we could see that if we gave zoledronic acid, we saw a significant increase in the bone volume. Overectomy decreased bone volume, but when we gave zoledronic acid to the overectomized animals, bone volume was increased to levels that were similar to the sham-operated animals, showing that zoledronic acid could overcome this overectomy-induced bone turnover. So things move on. So when we started this study, we said that zoledronic acid was the only agent that was licensed to treat breast cancer-induced bone disease. This is no longer the case, and we have more compounds that we can use. And one of the most exciting of these compounds in the clinic is denosumab. And denosumab is a fully human monoclonal antibody that binds RANK ligand. And this inhibits osteoclastogenesis. In clinical studies, it's been shown to be superior to zoledronic acid for preventing skeletal complications in patients with breast cancer bone metastases. However, we can't use this compound in our in vivo models because it's a human antibody. So we have to use the mouse variant, which is this FCOPG. So it acts exactly by the same mechanisms as denosumab does. And we investigated whether the effects of inhibiting OVX-induced bone resorption with this compound OPGFC. So first of all, what does this compound do to the bone environment? We can see, if you look at the goldness staining here, if you inhibit the RANK ligand interactions, you could increase the growth plate. But this isn't due to increased ossified bones. If you look at saffron orange staining here, this is increase in chondrocytes, not increase in ossified bones, so you get chondrocytogenesis. When we looked at bone-resorbing osteoclasts, we can see them clearly, the pink labelled cells here in the control. Couldn't see any in our FCOPG-treated animals, so we weren't able to score these. And we looked at osteoblasts. You can see these on the bone surface here in the control, and we couldn't see any on the FCOPG-treated bone. So FCOPG caused a significant increase in bone volume. This was due to a decrease in osteoclastic bone resorption and a decrease in osteoclastic bone formation. So what happened when we treated the animals with FCOPG? So we repeated the experiment that we did for the zoledronic acid, where we inoculated the MDA231 cells on day 0. We treated with FCOPG on day 4 or saline, and we overectomized or sham overectomized on day 7. And in these animals, we saw that following overectomy, as we'd expect, just as our control, we saw an increase in the tumour formation in bone. However, when we gave OPGFC, this significantly decreased. And this decreased to levels that were similar to the sham-operated. And again, these effects were specific to the bone microenvironment. So when we looked at tumour growth in other sites, there was no difference. And there was no difference in tumour growth in bone in the sham-operating animals. Interestingly, when we looked at tumour volume, so not just the number of tumours, so we looked by bioluminescence, we could see that in overectomized animals, when tumours did grow, they were a similar size to those that grew in the sham animals. So overectomy stimulated tumours to grow, but it didn't cause them to grow faster if they did grow. And And when we treated with FCOPG, although it didn't reduce the number of tumours that were formed in the pre-menopausal bone environment, it did reduce their growth, so they were much smaller. So we can say that OPGSE inhibits ovarectomy-induced proliferation of disseminated MDA-MB231 breast cancer cells in bone. So what happened to the bone environment? Well, we can see that in the bone, as expected, ovarectomy reduced the bone volume. When we gave FCOPG to sham-operated animals, this increased bone volume. And when we gave FCOPG to overectomized animals, this increased bone volume to levels that were similar to the sham bone environment, showing that FCOPG can overcome this overectomized-induced bone loss. This was due to increase in activity of osteoclasts, decrease in activity of osteoblasts. So we can say that FCOPG inhibits ovarectomy-induced bone resorption, leading to a net increase in bone volume and a decrease in bone cell activity. So in summary, what have we found? So we know tumour cells arrive early in the bone, and then for most patients they remain dormant. These cells can be stimulated out of dormancy following in a postmenopausal bone environment or following ovarectomy, and this leads to release of growth factors from the bone. This stimulates the tumour cells to grow. These tumour cells then cause this vicious cycle where the tumour cells feed the bone and the bone cells feed the tumour. If we give zoledronic acid or FCOPG and supposedly denosumab, then this inhibits these tumour cells from being stimulated out of dormancy so that they remain dormant in the bone environment. So what we can say, just to wrap things up, because I'm being looked at from the side, is that our data support early intervention with anti-resorptive therapy in a low estrogen environment to prevent the development of bone metastases. I'd like to thank all these people for their help in the laboratory, and thank you for your time.